Welcome back to the Deep Dive, the place where we cut through the information noise, synthesize the densest research, and deliver the highest yield knowledge right to you.
Today, we are undertaking a really deep dive into one of the most foundational, I'd say, life-critical areas of surgical management: perioperative nutrition and fluid therapy.
Yeah, absolutely critical. It sounds basic, maybe, but the complexity underneath is huge.
Oh, it is. This isn't just theoretical stuff. This is the absolute core of patient management. It's all dictated by how the body responds metabolically to stress, to illness.
So for anyone listening, whether you're studying or practicing surgery, getting this chapter down cold.
Knowing when to step in, and crucially, how to intervene safely. Well, that's the bedrock. It's how you prevent complications, how you ensure patients actually recover well.
Our mission today is pretty clear then. We're distilling this entire chunk of source material, really essential stuff for surgical practice, into concepts you can actually remember and use.
Yeah, making it digestible, memorable. We're talking about keeping patients metabolically stable when their bodies are under, well, extraordinary strain.
And that strain, it often starts way before they even get to the operating theater, doesn't it?
Absolutely. The source material makes that painfully clear. The underlying reasons people need surgery: major cancer, severe IBD, big trauma. These things frequently cause malnutrition before we even get involved.
You look at figure 25.1 in the source.
Yeah.
It shows that impact, right? The wasting.
It does. Profound muscle and fat wasting. That's the result of long-term lack of calories, lack of protein.
So that's the starting point. The patient's already behind.
Exactly. They're starting with a deficit. And then the surgery itself, particularly big abdominal procedures.
Right. Those can really mess with the gut.
They can temporarily or even permanently compromise the one thing they need most:
Right.
the GI tract's ability to actually absorb food.
So if you combine that pre-existing malnutrition with not being able to eat properly post-op,
Recovery is severely compromised. It's a setup for failure.
which means that old approach, just sort of waiting for the patient to get better and start eating on their own.
That's essentially malpractice these days. It's a failing approach, yeah.
So the goalposts have shifted. It's not just about fixing the anatomy anymore.
No, it's about aggressively correcting those nutritional and fluid deficits and doing it early. There's this increased appreciation now for how vital nutritional status is.
And that's driven changes in practice.
Big time. We have better assessment tools now, much improved ways to deliver food, both enterally and parenterally, and the formulations themselves are safer, more balanced.
So the focus is really on catching and treating these deficiencies as soon as possible.
That's the modern approach. Proactive, early intervention. #tag2, physiological responses to nutritional impairment.
Okay, so before we dive into fixing the problem, we really need to understand what breaks down metabolically when a patient is sick or just starved.
Right. Let's start with the non-negotiable: the body's constant critical need for glucose.
That's priority number one.
Unwavering priority. Tissues like the brain, red blood cells, white blood cells, the renal medulla, they have to have glucose. They're obligate consumers.
So maintaining glucose homeostasis is key, eating or not.
It has to be maintained. #tag. Metabolic response to fasting or starvation.
Let's take simple fasting first. Say the first 24 hours, the body's relatively calm, metabolically speaking. Where does it get its fuel initially?
It goes straight for the easy access stash, stored carbohydrate. So insulin levels drop quickly, counter-regulatory hormones, mostly glucagon, start to rise.
And that triggers
Glycogenolysis, breaking down stored glycogen in the liver and muscles into glucose that can circulate.
And there's a cycle involved here, often using lactate.
Yeah, what's fascinating is the cyclical nature, often involving lactate. It's the Cori cycle.
Kokori cycle. Where does that name come from? Is there a story there?
Yeah, good question. It's a neat bit of history. Named after Gertie and Carl Cori, a husband and wife team who won the Nobel Prize.
Oh, wow.
Yeah, they brilliantly figured out how lactate, produced in muscles during activity or fasting, travels through the blood back to the liver.
And gets converted back to glucose.
Exactly. It's a really efficient way to recycle these energy substrates, keeping the brain fueled when food is scarce in the short term.
But those glycogen stores, they don't last forever.
Nope, they run out pretty quickly. Once you push past that first 24 hours, maybe towards 40 hours, that source is pretty much depleted.
So the body has to switch gears, start making fuel.
That's the cue for gluconeogenesis, making new glucose from things that aren't carbohydrates.
What are the building blocks for that?
The main ingredients are amino acids, specifically glutamine and alanine, which get liberated from breaking down muscle protein along with lactate. and also glycerol from fat breakdown.
Okay, and this is where the muscle loss really starts to kick in, right? The body literally eating its own structure.
Precisely. Catabolizing skeletal muscle becomes the default way to get those amino acid precursors. For an average adult, this can generate up to 75 grams of amino acids every day.
All just to keep the glucose levels up for the brain.
All directed towards that, yes.
But the body is incredibly adaptive. If starvation goes on longer, say past 48 hours, it shifts strategy again, doesn't it, to save that muscle?
It makes a major metabolic pivot. This is the critical shift towards lipolysis, breaking down fat stores.
Okay.
So the fatty acids from fat get converted into ketone bodies. The glycerol backbone from the fat molecule can still be used for a bit of glucose production, but the main event is ketones.
And tissues start using ketones instead of glucose?
Most tissues adapt remarkably well. They start using ketones as their primary fuel, brain included to a large extent. Red cells still need glucose, though.
And the benefit is?
It dramatically reduces the body's dependence on glucose, which means it significantly slows down the rate of muscle breakdown. It's trying to preserve protein.
And the overall energy expenditure drops too, right? Summary box 25.1 shows that.
Yeah, the resting energy expenditure, or REE, can fall quite dramatically, maybe from 25, 30 kilocalories all day down to 15, 20.
The body's basically turning down the thermostat.
Yes, exactly. Partly by reducing the conversion of inactive thyroid hormone T4 to the active form T3. It's a deep conservation effort.
A survival mode.
A remarkable survival mechanism.
Yeah.
But, and this is important even in this highly conserved state, the brain and those other essential tissues still need about 200 grams of glucose per day. That demand never fully goes away.
So conservation, yes, but still spending vital resources.
Always. Hashtag BBAR. Metabolic response to trauma and sepsis.
Okay, that's simple starvation, relatively controlled, adaptive. But surgical patients, they're rarely just simply starved. They've got trauma, sepsis, the fallout from big surgery.
Right. And the metabolic response here is completely different. Summary box 25.2 calls it the stress response. And, well, it's a metabolic train wreck compared to quiet starvation.
How so? What drives it?
It's an inflammatory storm. The body needs to repair tissue, fight infection. So you get this early rapid surge of counter-regulatory hormones, catecholamines like adrenaline, glucocorticoids like cortisol, glucagon growth hormone.
And insulin.
And insulin too. But the body often becomes resistant to its effects, which we'll get to. Crucially, the energy requirements don't drop, they actually increase.
Increase by how much?
Sometimes spiking up to 40 kilocalories per day. The body needs fuel for tissue repair for all those hyperactive inflammatory cells.
Okay, so we've gone from conserving energy in starvation to just burning through everything in the stress response.
Pretty much. Throwing gasoline on the fire is a good way to put it.
Yeah.
And this is where the muscle loss becomes catastrophic.
Why is it worse here?
Those elevated stress hormones drive persistent, aggressive breakdown of tissue protein. You get this severe, sustained negative nitrogen balance.
Just losing protein constantly.
Constantly. And here's the key difference that really dictates how we manage these patients.
Yeah.
That adaptive shift to using ketones we saw in starvation.
Yeah.
It's often severely impaired, or sometimes completely absent in severe trauma and sepsis.
Okay, so that's the trap. If the body can't switch efficiently to using fat and ketones...
It has no choice but to keep hammering the muscle protein for gluconeogenesis.
Yeah.
Even if you're pumping calories into the patient.
Wow. That's a vicious cycle.
It is. And it's made even worse by profound insulin resistance. This is often called the surgical factor.
What causes that resistance?
Stressors like pain, tissue damage, acidosis, they all trigger hormonal and inflammatory responses that make the cells resistant to insulin signal.
And clinically, we see that as high blood sugar, right? Hyperglycemia.
Exactly. Even if glucose is available, it can't get into the peripheral tissues efficiently.
Why not? What's the mechanism?
It boils down to the failure of a specific protein, the glucose transporter called GLUT4. Normally, insulin tells GLUT4 to move to the cell surface and let glucose in, especially into muscle cells.
But in the stress state?
That signaling pathway is inhibited.
Yeah.
GLUT4 activation is reduced, so muscle cells effectively refuse the glucose.
Which forces the liver to?
Keep making more glucose by breaking down muscle protein, because the body still perceives a need for glucose even though there's plenty around.
So you're losing muscle and you've got high blood sugar damaging things like the immune system and wound healing.
It's a double hit, a really damaging situation.
And understanding this whole metabolic picture, that's what's driven changes in how we care for surgical patients.
Absolutely. It's led to a revolution, really. Modern interventions are specifically targeted at dampening this severe stress response.
Things like the enhanced recovery after surgery, the ERES protocols.
Exactly. Things like giving preoperative high-carbohydrate drinks. The idea is to load the system and improve insulin sensitivity before the stress hits,
Makes sense.
prioritizing minimally invasive surgery to reduce the amount of tissue damage and inflammation, and that aggressive focus on getting patients moving early mobilization.
All aimed at minimizing that damaging insulin resistance.
Minimizing its impact, shortening its duration, it all ties back fundamentally to understanding this metabolic response to injury.
Okay, the metabolic picture is clear, and it can be pretty grim. But before we jump in with feeding tubes and IV lines, we need to know who actually needs help, right? Assessment first.
Absolutely crucial. You don't want to feed aggressively if it's not needed, or worse, if it's dangerous. The source organizes this assessment really nicely using the ABCD approach.
ABCD. Okay, A is for?
Anthropometry. Basically, measuring the physical body to get an idea of its composition, its energy, and protein stores. Hashtag, tag, A, anthropometry.
So what kind of measurements are we talking about?
Well, the basics like weight and calculating BMI, which are easy to get. But ideally, you also look at things like mid-upper arm circumference, MUAC,
Right.
skin fold thickness, usually the triceps, so TSF. And from those two, you can calculate the mid-arm muscle circumference, or MAMC.
And those give a better sense of muscle versus fat stores.
They attempt to, yeah. Trying to get a clearer picture beyond just the number on the scale.
Now, what about the actual red flags, the specific numbers that tell us, right, this patient needs nutritional support now?
We need to look for a combination of factors. The source gives clear criteria. Criterion 1, a BMI less than 18.5 kilotrimon (2) combined with unintentional weight loss of more than 10% over the last 3 to 6 months.
Okay, BMI under 18.5 A&D, weight loss over 10%. Got it.
Or criterion 2, a slightly higher BMI, less than 20 kilotrimon, but still with significant unintentional weight loss, this time greater than 5% in that same 3 to 6 month window.
BMI under 20 A&D, weight loss over 5%.
Right. If a patient meets either of those combinations, it should trigger an immediate referral to the nutrition support team or initiation of support.
But there's a big but here, isn't there? Especially in sick patients.
Huge caveat. In critically ill patients, these simple anthropometric measures can be really deceptive.
Why is that?
Think about it. Aggressive fluid resuscitation, edema, massive fluid shifts that happen with sepsis or major surgery.
Ah, so their weight might go up even if they're losing muscle.
Exactly. A patient can gain 10 kilos of fluid overnight while simultaneously breaking down significant muscle mass. So BMI and weight alone have to be interpreted very cautiously in that acute setting. Hashtag, tag, B, biochemistry.
Okay, so A is anthropometry, B is for?
Biochemistry. Looking at the blood tests, we're scanning for signs of inflammation, infection, and potential chronic deficiencies.
What markers are key here?
Well, you look at things like C-reactive protein, CRP, and white cell counts. They're general flags for inflammation and infection, which we know drive catabolism and worsen nutritional status.
Makes sense.
But the marker everyone always talks about is albumin.
Right, low albumin often gets equated with malnutrition, but the source says it's unreliable in the acute setting.
It is unreliable, yes, for a couple of reasons. First, albumin levels are heavily influenced by fluid balance. If a patient is fluid overloaded, their albumin gets diluted, making it look falsely low.
Right.
But more importantly, albumin is what we call a negative acute phase reactant, meaning during inflammation or sepsis, the liver actively suppresses albumin production and ramps up production of positive acute phase reactants, like CRP.
Ah, so a low albumin might just reflect how sick they are acutely, not necessarily their long-term nutritional state.
Exactly. It's more a marker of illness severity in the short term. It can be useful to track recovery over weeks, but it's not a great snapshot indicator of nutritional status today.
So what are the crucial blood tests we need, especially before starting any aggressive feeding?
We absolutely must check hemoglobin looking for anemia. Often points to vitamin or iron deficiencies. Glycated hemoglobin, HbA1c, is vital if the patient has diabetes, tells us about their long-term control.
And crucially,
We need baseline electrolytes, particularly potassium, magnesium, and phosphate. Calcium, too. These are non-negotiable
why are they so critical at baseline?
because these are the electrolytes that plummet during refeeding syndrome. We need to know the starting point to anticipate and prevent those potentially fatal shifts when we start feeding. Hashtag C and C. Clinical evaluation and dietary assessment.
Right, makes sense. So C is clinical evaluation. This is about the history and symptoms.
Yes, a thorough clinical evaluation. Are there symptoms actively stopping the patient from eating or absorbing nutrients? Things like nausea, vomiting, difficulty swallowing, dysphagia, feeling full really quickly, early satiety, or chronic problems like diarrhea or constipation.
And the past medical history is key, too.
Absolutely. Conditions like cancer, inflammatory bowel disease, IBD, significant liver disease, neurological conditions that affect swallowing, or things caused by previous surgery like short bowel syndrome or a high-output stoma or fistula. Anything that impairs absorption needs to be flagged.
Okay. And finally, D is?
Dietary assessment, trying to quantify the gap between what they need and what they're actually getting.
How do we estimate their needs quickly?
A rough estimate for energy requirements in a reasonably stable adult is somewhere between 25 and 35 kilocalories per kilogram of lean body weight per day.
Lean body weight, not total weight.
Ideally lean body weight, yes. And you adjust that upwards depending on how stressed they are. Trauma, fever, sepsis, all increase needs and their activity level, if any.
And when does this assessment tell us they need artificial support?
It's pretty straightforward. If their current estimated intake is consistently falling short of those calculated requirements, or, perhaps more importantly, if you anticipate they're going to eat little or nothing for more than 5 days straight.
Because of the surgery planned or expected gut issues post-op.
Exactly. Then they need proactive nutritional support. Don't wait for them to become visibly malnourished. ###D, the Malnutrition Universal Screening Tool.
This seems like a lot to pull together quickly in a busy ward setting. Is there a tool to help standardize this?
Yes, thankfully. The Malnutrition Universal Screening Tool, or MUST, is developed by BAPN, the British Association for Parenteral and Enteral Nutrition.
And its purposes?
It's designed as a rapid screening tool. It's objective, easy to use, and can be applied in hospitals, clinics, even in the community. It gives a score that directly guides action.
Okay, how does the scoring work? Figure 25.2 lays it out. 3 components.
3 key components, weighted equally. First is BMI. If it's less than 18.5, that's considered severe risk, scores 2 points straight away.
Component 2.
Recent documented unintentional weight loss in the last 3-6 months. If it's more than 10% of their usual weight, that also scores 2 points. Between 5 and 10% scores 1 point.
Okay. And the third component addresses the immediate situation.
Exactly. It's called the acute disease effect. If the patient has had, or is likely to have, very little or no nutritional intake for more than 5 consecutive days.
Like someone with a bowel obstruction coming in.
Perfect example. That acute lack of intake adds another 2 points to the score.
And then you add up the points, and the total score tells you what to do.
Precisely. A score of 0 means low risk, just routine clinical care.
Score of 1.
Medium risk. The protocol here is to observe. You need to meticulously document their food intake for 3 days, then repeat the MST screening. Keep a close eye on them.
And a score of 2 or more.
That's high risk. This is a hard stop. You must initiate treatment. That means referring to the specialist dietitian or the nutritional support team, implementing your local feeding policies, and getting nutritional support started promptly.
So it's a system designed to catch those at risk early and prevent them falling through the cracks.
Exactly. Takes the guesswork out and mandates action. #IvyKeen, fluid and electrolyte replacement.
Assessment complete. We know who needs help. Now, the second critical pillar you mentioned, fluids and electrolytes. These seem almost inseparable from nutrition in surgical patients.
They are utterly interwoven, especially when you have ongoing losses from drains, fistulas, or poor intake. You can't manage one without the other. #AI, daily fluid balance and maintenance.
Let's start with the basics again. What does normal daily fluid balance look like? Table 25.1 gives the numbers for a healthy 70-kilogram adult.
Right. Roughly 2.5 liters of intake should balance about 2.5 liters of output. Intake comes from drinks, maybe 1.2 L, water and food, about 1 L, and then around 300 ml the body actually produces metabolically.
And output is mostly urine, about 1.5 liters. But there's also this significant insensible loss. What's that?
That's the fluid we lose without noticing it, mainly through evaporation from the skin and water vapor in our breath, usually around 900 milliliter, so nearly a liter a day.
And that amount can change?
So yes, it increases significantly if you have a fever, pyrexia, if you're exerting yourself, or if you're in a very warm environment.
And there's a specific surgical point about tracheostomies.
Yes, really important detail. A tracheostomy bypasses the natural humidification system of the nose and upper airways. so patients lose much more water through respiration.
Meaning you have to.
You must provide humidified air or oxygen to them, otherwise they can get severely dehydrated very quickly from those increased insensible losses.
Okay, so adding it all up, what's the typical daily maintenance fluid requirement for that 70-kilogram adult?
Roughly 2.2 liters per day, or a good rule of thumb is about 30 milliliters per kilogram per day.
And what about the electrolytes needed just for maintenance?
Daily needs are around 0.9 to 1.2 millimoles per kilogram per day for sodium. Potassium is simpler, about 1 millimoles per kilogram per day.
And the others?
Don't forget calcium, about 5 millimoles per day, and magnesium, around 1 millimole per day. These baseline amounts are needed even if there are no extra losses.
And the route of delivery. Simplest is best.
Always. If the patient can drink, oral rehydration solutions are the gold standard. If they can't swallow but the gut works, use an enteral tube. FAV fluids are really the last resort.
Reserved for when?
When the gut just can't absorb adequately, or when the losses are so large they simply can't be kept up with enterally. #B intravenous fluid replacement solutions.
So when AV fluids are the only option, the choice of fluid becomes critical. Table 25.2 is fantastic here, comparing common solutions side by side with plasma.
Yeah, this comparison is something everyone managing fluids needs to internalize. What's striking is just how different most standard IV fluids are from our own plasma.
Plasma is balanced, buffered.
Right. Physiologically appropriate sodium, around 135, 145 millimole L. Chloride, 95, 105 millimole. Physiological pH.
Okay, now look at 0.9% saline, often called normal saline, which is ironic given these numbers.
Exactly. It's got 154 millimole of sodium and 154 millimole of chloride, both significantly higher than plasma.
And that has consequences.
Certainly can, especially if you give large volumes. That high chloride load can overwhelm the kidney's buffering capacity and lead directly to a hyperchloremic metabolic acidosis. Plus, look at the pH of saline itself. It can be as low as 4.5. It's acidic.
Right. So Hartmann's solution, or lactated ringers, is often seen as more physiological. Why is that?
Hartmann's is much closer. Sodium is 131, potassium is 5 millimole, but the key is the lactate. It contains 29 millimole.
And the body uses that lactate.
The liver rapidly metabolizes that lactate into bicarbonate, effectively giving the fluid a buffer capacity of 29 millimole. This makes it much less likely to cause acidosis compared to large volumes of saline.
Okay, and then there's 5% dextrose, just glucose, no electrolytes.
Essentially free water. Yeah. Once the glucose is metabolized, you're left with water. It's used mainly to replace pure water deficits, like insensible losses, or to correct hypernatremia, but it provides no electrolytes for maintenance or replacement.
So the big takeaway from this table is?
There is no single perfect 5E fluid that matches plasma exactly. The fluid you choose must be tailored to the specific patient, their underlying problem, and crucially, the type of fluid they are losing.
What about colloids? Things like gelifusine. They're meant to stay in the circulation longer.
That's the theory. They contain large molecules designed to increase oncotic pressure and hold fluid intravascularly, acting as plasma extenders.
But there's controversy.
Yes, quite a bit. Large studies have questioned whether they offer significant benefit over crystalloids for resuscitation, and some types have been linked to increased risks of acute kidney injury or problems with blood clotting, coagulopathy. Their use is much more restricted now.
And albumin.
Generally not recommended for routine volume resuscitation. It has specific indications, like replacing fluid removed during paracentesis for ascites, or in some specific liver failure scenarios, but not as a general resuscitation fluid.
And the final rule, if the loss is blood.
The best replacement for blood loss is blood, period. ###C, assessment and fluid loss composition.
So making that tailored fluid choice requires careful monitoring. What are we watching?
We look at the standard hemodynamics, pulse, blood pressure. If they have a central line, central venous pressure, CVP, gives an idea of intravascular volume. But just as important, maybe more so, is accurate fluid balance charting.
Tracking everything in and out.
Meticulously. Urine output, yes, but also output from surgical drains, nasogastric tubes, stomas, fistulas, even estimating significant diarrhea losses. And regular checks of serum electrolytes and hematocrit are essential to see if your replacement strategy is working.
And table 25.3 is key here because it shows that the composition of fluid lost from different parts of the GI tract varies hugely.
This is critical clinical knowledge. It dictates the type of replacement fluid you need.
Give us an example. High NG tube output.
Okay, patient with gastric outlet obstruction, putting out lots of fluid via an NG tube. They're losing gastric juice. What's in that? It's high in chloride, around 110 millimole, and hydrogen ions. It's acidic. Moderate sodium, maybe 50 millimole. Low potassium.
So losing lots of chloride and acid leads to...
A hypochloremic metabolic alkalosis. They become alkalotic because they're losing acid. You need to replace that chloride often with saline and potassium.
And the opposite happens with lower GI losses.
Exactly. If the loss is from further down pancreas, bile duct, small bowel fistula, high output ileostomy, that fluid is very different. It's typically high in sodium, around 140 millimoles, similar to plasma, and very rich in bicarbonate, especially pancreatic fluid, which can have over 100 millimole of bicarb.
So losing that fluid causes
Profound dehydration and a metabolic acidosis because you're losing base, bicarbonate. Replacement here needs a balanced salt solution, like Hartmann's, or even fluids with extra bicarbonate added, plus potassium.
So you absolutely cannot use a one-size-fits-all approach.
You really can't. Understanding the likely composition of the losses based on the source is fundamental to choosing the right replacement fluid and preventing dangerous electrolyte and acid-base imbalances. #Tag V, nutritional requirements.
Okay, assessment done, fluids getting sorted. Now let's talk about the actual fuel, figuring out the energy and nutrient requirements. #Tag V, total energy intake and calculation.
Right. The starting point for planning any feed is usually estimating the basal metabolic rate, or BMR, how much energy the body burns just at rest.
And we use equations for that, like Harris-Benedict.
Exactly. The Harris-Benedict equations are the classic ones. They plug in the patient's weight, height, age, and sex to predict that baseline energy expenditure.
It's amazing science, developed over a century ago, right? Harris and Benedict.
Yeah, foundational work adapting calorimetry for human physiology. But that equation gives us the predicted BMR. What's the actual clinical requirement for a sick patient?
Does it go up much?
For a stable but unwell patient, their actual requirement is typically around 20 to 30 kilocalories per kilogram of ideal body weight per day. Even with severe stress, like major trauma or sepsis, the hypermetabolism rarely pushes needs beyond 120% of that predicted BMR, so maybe up to 30 kilocalories in those cases.
Okay, and you emphasize ideal body weight there. Why is that distinction so important?
Absolutely critical. If you use the patient's actual weight, especially if they're obese, you will massively overestimate their energy needs. Adipose tissue, fat, is metabolically much less active than muscle.
And overestimating leads to?
Overfeeding.
Yeah.
Which the source clearly states is a very common cause of complications, whether you're feeding via tube or IV.
What kind of complications does overfeeding cause? Why are we so cautious about it?
Well, it puts a huge metabolic strain on the body. Forcing the system to process excess calories, especially carbohydrates, generates a lot of carbon dioxide, CO2.
Which is bad
If the patient already has respiratory problems, maybe they're on a ventilator, that extra CO2 load can make it harder to wean them off, potentially even causing respiratory failure. Overfeeding also worsens hyperglycemia, insulin resistance, and can lead to fatty changes in the liver.
So the rule is start slow, especially in high-risk patients.
Definitely. If the patient is severely stressed or you know they're at high risk of refeeding syndrome, you must start cautiously. No more than 50% of their estimated target needs initially, maybe even just 10 kilocal per kilogram per day to begin with.
And then increase gradually.
Slowly increase towards the full requirement, maybe over 24 to 48 hours for a standard patient, but potentially taking 4 to 7 days for those at highest risk of refeeding. Caution equals safety here. #Tag B macronutrients.
Okay, let's break down the fuel mix, the macronutrients, starting with carbohydrate.
Right. Carbs, usually given as glucose, are the central fuel, especially for the brain and blood cells. The body needs the equivalent of at least 2 grams of glucose per kilogram per day just for those basic functions.
And in a typical feed, what proportion should be carbs?
Generally, carbs should make up the bulk of the energy, somewhere between 45% and 65% of the total caloric intake.
Next, protein. Needs go up in illness, you said.
Sharply, yes, because of that catabolic stress response we talked about. The goal of giving protein is to provide the building blocks for tissue repair and try to counteract that negative nitrogen balance.
How much protein are we aiming for?
Daily nitrogen needs increase quite a bit. We often aim for up to 0.25 grams of nitrogen per kilogram per day, which translates to roughly 1.5 grams of actual protein per kilogram of ideal body weight per day.
And as a percentage of total energy?
Protein should probably make up around 20% of the total energy intake.
Okay. Lastly, fat. It's more than just calories.
Right. Fat provides essential fatty acids, linoleic and linolenic acid, which the body can't make itself. They're vital for cell membranes, inflammation modulation, lots of things.
And how is fat used in artificial feeding, especially IV feeding?
When we get parenteral nutrition, PN, we usually use a lipid emulsion. We combine giving fat, maybe 100, 200 grams total per week, with the minimum amount of glucose, say 100, 200 grams per day.
Why the mix?
This mixed fuel approach is metabolically safer. It helps the body utilize the substrates efficiently. It minimizes the risk of fluid retention compared to giving just glucose. And importantly, it significantly reduces that CO2 production we worried about with overfeeding pure carbohydrate. Hashtag C. Vitamins, minerals, and trace elements.
Easy to focus on the big three: carbs, protein, fat, but the micronutrients are just as vital, aren't they? Especially vitamins B and C.
Absolutely critical. They're like the spark plugs and lubricants for the metabolic engine. Vitamin C is essential for collagen synthesis, wound healing. Post-operatively, the requirement actually increases maybe to 60, 80 milligrams per day.
And B vitamins.
Crucial cofactors in energy metabolism. Thiamine, vitamin B1, is probably the single most critical one to give immediately when starting any feed, especially in malnourished patients, to prevent the neurological damage of refeeding syndrome, like Wernicke's encephalopathy.
Are there specific patient groups who need extra attention for certain vitamins?
Definitely. Anyone with a history of significant alcohol abuse or patients who've had gastric surgery like a gastrectomy needs routine supplementation with thiamine, B12, and folate.
Why gastric surgery specifically for B12?
Because the parietal cells in the stomach lining produce intrinsic factor, which is absolutely essential for absorbing vitamin B12 further down in the ileum. Remove the stomach or bypass it, and you lose that intrinsic factor, leading to B12 deficiency.
Makes sense. And what about conditions that affect fat absorption?
If you have reduced pancreatic enzyme output or bile flow is obstructed, you'll have trouble absorbing fat, and that means you'll also malabsorb the fat-soluble vitamins A, D, E, and K. They need monitoring and replacement.
And electrolytes and trace elements, again, continuous losses are a big issue.
Huge. Chronic diarrhea, high stoma output, these can relentlessly deplete sodium, potassium, magnesium, and critically phosphate. We also need to think about trace elements like zinc, copper, selenium, iron. They're all crucial cofactors for enzymes involved in healing and metabolism. Replacement is often necessary, especially to prevent or manage refeeding syndrome. Hashtag tag 6, effects of intestinal resection.
Okay, let's shift focus now to a very specific surgical situation where nutrition becomes a central, often permanent challenge. Intestinal resection, losing parts of the bowel, hashtag tag A, intestinal adaptation and loss.
Right. The intestine is an amazing organ. It has this huge capacity for adaptation after parts of it are removed. The remaining bowel can actually grow, the villi get taller, it produces more transporter proteins to try and compensate.
Does it matter which part of the bowel is removed?
Oh, enormously.
Why?
If you resect a portion of the proximal jejunum, the early part of the small intestine, the ileum further down, and the colon, can often compensate remarkably well. Supplemental nutrition might be needed temporarily, but often not long-term.
But losing the ileum? That's different.
Much more significant, yes. The ileum has unique functions that the jejunum can't fully replicate.
Like absorbing bile salts.
Exactly. The terminal ileum is where virtually all bile salt reabsorption happens. If you lose, say, the last 100 centimeters of ileum, you significantly impair that process.
What happens then?
The bile salts spill over into the colon. They irritate the colon lining, drawing water in, causing osmotic diarrhea. They also interfere with fat absorption, leading to steatorrhea, fatty, greasy stools.
Can that be managed?
Sometimes, if the loss isn't too extensive, a medication called cholestyramine, which binds bile salts, can help control the diarrhea. But often, patients need to significantly restrict their dietary fat intake.
And if the ileal resection is even larger?
Then the fat restriction becomes essential. But you also get another problem. Loss of the ileum tends to increase gastric emptying and speed up overall intestinal transit. Things just rush through too quickly.
Compounding the diarrhea and malabsorption.
It's exactly. Less contact time for absorption, more fluid hitting the colon faster than it can handle. Persistent diarrhea and major fluid and electrolyte losses become the norm. Hashtag tag B, short bowel syndrome, SBS.
And when the resection is massive, we get into the realm of short bowel syndrome, or SBS. The source defines this as typically less than 200 centimeters of remaining small intestine.
That's the general threshold where you see the most severe consequences, yeah. Significantly reduced absorptive surface area leads to chronic, potentially life-threatening malnutrition and dehydration.
SBS isn't static, though, is it? There are phases.
Right. We think of it in two main stages. First is the acute stage, right after the massive resection. This lasts for the first few weeks.
What characterizes that stage?
Extremely high intestinal losses, often fluid output from stomas or diarrhea exceeding 4, 5, even 6 liters a day. You also often see gastric hypersecretion, the stomach pumping out excess acid, driven by high gastrin levels.
Sounds incredibly unstable.
It is. This period demands really aggressive IV fluid and electrolyte management just to prevent acute kidney injury and severe acid-base chaos. Patients are often critically ill.
But then comes the adaptation stage. There's hope for improvement.
Yes, thankfully. Over the next 1 to 2 years, that remaining bowel undergoes those structural and functional changes. We talked about villus hypertrophy, increased transporter expression. It gradually gets better at absorbing nutrients and fluid.
Does everyone adapt fully?
Not everyone, but many patients do improve significantly. Their symptoms lessen, their nutritional status stabilizes. Some are even able to eventually wean off the parenteral nutrition, the IV feeding. That was essential initially.
It's a long process.
A very long process. And even after maximal adaptation, many patients still require specialized diets, oral supplements, specific medications like anti-diarrheals or agents to slow transit, often for life. The source notes that if weaning off PN hasn't happened within about 3 years, lifelong dependency is unfortunately likely.
Let's talk about the most severe cases, say. Less than 100 centimeters of small bowel left. The fluid management here sounds really tricky, almost counterintuitive.
It is. This is a situation where patients literally lose more water and salt in their stool or stoma output than they can possibly absorb from normal drinks. Daily losses can be enormous.
And the key management point is restricting certain types of fluids.
Critically important, they need to strictly restrict their intake of hypotonic fluids, meaning fluids with a low sodium concentration, typically less than 90 millimole. Things like plain water, tea, coffee, juice, usually restricted to less than a liter per day.
Why restrict water? That seems odd when they're dehydrated.
It's about osmosis. In such a short, compromised bowel, drinking hypotonic fluid creates a strong osmotic gradient, pulling sodium and water out of the bloodstream and into the bowel lumen.
So drinking water actually makes the dehydration and salt loss worse.
Paradoxically, yes. It increases stool or stoma output. So these patients must rely on isotonic or slightly hypertonic oral rehydration solutions, ORS, like diarrheolite or similar preparations containing glucose and salt in the right proportions.
Because those promote absorption rather than secretion.
Exactly. The glucose co-transports with sodium, helping to drive net absorption of salt and water rather than causing further losses. It's a vital management principle for severe SBS.
Okay, we've seen the consequences of gut failure. Let's pivot back to intervention. We've assessed the patient. We know they need support. When do we actually pull the trigger and start artificial feeding?
The general rule of thumb is, if you anticipate inadequate oral intake for 5 days or more, consider artificial support.
Sooner if they're already malnourished.
Absolutely. If they have pre-existing chronic malnutrition or if they're about to undergo really high-risk surgery, think major cancer operations like esophagectomies, gastrectomies, pancreatic resections, you should ideally start nutritional support before the operation. Be proactive.
And sometimes that means putting in a feeding tube during the surgery itself.
Yes, very common practice now. For example, placing a feeding jejunostomy tube distal to the surgical site during a big upper GI operation, anticipating that the stomach won't work properly for a while post-op, but wanting to feed the patient early. ###A. Indications and preference.
Now, why is enteral nutrition feeding directly into the GI tract so strongly preferred over intravenous feeding, parenteral nutrition, whenever possible, even if the patient is quite sick?
The benefits of using the gut are just profound. It's not just about delivering calories.
What else does it do?
First and foremost, keeping the gut fed helps maintain the integrity of the gut lining, the mucosal barrier. This is crucial for preventing bacteria and toxins from leaking out of the gut into the bloodstream, a process called bacterial translocation, which can drive sepsis.
So it supports gut immunity.
Yes, and prevents gut atrophy, the lining becoming thin and leaky from disuse.
Huh.
Clinically, using EN is consistently associated with lower rates of infection, better wound healing, and shorter hospital stays compared to relying solely on PN.
So the mantra is,
If the gut works, use it. Even if it's only working partially, try to get some feed in there, even if you need supplemental PN alongside it. Trophic feeding. ###B delivery methods.
okay, so how do we deliver EN? What are the options?
Well, the simplest start is often oral nutritional supplements, ONS. Those are the liquid sip feeds, shakes, usually providing around 200 kLs and maybe 8-10 gram protein per 200 milliliter bottle. Good for boosting intake or weaning people off tubes.
And if they can't manage ONS or need more reliable delivery, then it's tube feeding.
Right, and we categorize tubes mainly by where the tip sits. You have prepyloric feeding, meaning the feed goes into the stomach.
How do we achieve that?
Usually via nasogastric NG tube like a Ryle's tube, though fine-bore feeding tubes are better tolerated long-term, or via a gastrostomy tube placed directly through the abdominal wall into the stomach.
And the alternative is post-pyloric feeding.
Yes, bypassing the stomach. The feed goes directly into the small intestine, usually the jejunum. This is done via a nasogenal NJ tube or a feeding jejunostomy tube.
Why bypass the stomach? What's the advantage there?
It's particularly useful if the patient has problems with delayed gastric emptying, or if they're very high risk of aspirating feed from the stomach into their lungs. Post-pyloric feeding allows you to feed them safely without resorting to TPN in those situations.
And starting the feed itself needs careful planning.
Always. It should be planned by a dietitian. And as we keep saying, start slow, especially if there's any risk of refeeding syndrome.
What kind of rates are typical?
Often start very cautiously, maybe 10 or 20 milliliters per hour, and then gradually increase the rate every few hours or daily, aiming for a target rate, perhaps up to 75 or 100 ml/hour, depending on the feed concentration and patient tolerance.
Tube care is important too. Blockages.
A meticulous flushing with water, usually before and after feeds or medications, is essential to prevent the tube blocking up, which is a common frustration.
And if it does block?
Try flushing gently with warm water. But the absolute safety rule, never, ever try to unblock a feeding tube by reinserting the guide wire that came with it.
Why?
Because the guide wire is stiff and sharp. If the tube has migrated slightly or kinked, you can easily perforate the esophagus, stomach, or bowel. It's incredibly dangerous.
Got it. No guide wires. And confirming the tube is in the right place before starting the feed is mandatory.
Absolutely mandatory. Safety check number 1. For a standard NG tube going into the stomach, the first check is usually aspirating fluid and testing its pH.
What pH are we looking for?
A pH of 5.5 or less is generally considered reliable confirmation of gastric placement. If the pH is higher, or you can't get an aspirate, or if the patient is high risk, for e.g. unconscious, sedated, then you must get a chest x-ray, CXR.
And what does the CXR need to show?
The source is specific. The tip of the tube must be clearly visible below the diaphragm, and it should ideally bisect the carina or pass beyond the bronchial bifurcation, ensuring it hasn't gone down an airway or coiled up in the esophagus.
What about nasojejunal tubes? They go further down.
NJ tubes are harder to place correctly. They usually require endoscopic or radiological guidance to get the tip past the pylorus into the jejunum. You can't just insert them at the bedside and assume they're right.
So confirmation for NJ tubes
Always requires an abdominal x-ray to confirm the tip is definitely in the small bowel before you start feeding. #C. Long-term access, gastrostomy, and jejunostomy.
Okay, those nasal tubes are usually for shorter-term feeding. If someone needs EN for longer, say more than 4-6 weeks.
Then we start thinking about more permanent access, usually gastrostomy or sometimes a jejunostomy tube placed directly through the abdominal wall.
This sounds like a bigger decision.
It is. It involves a procedure, potential complications, and impacts lifestyle. It really needs a proper discussion involving the patient, family, and the multidisciplinary team.
What's the most common type of gastrostomy?
The percutaneous endoscopic gastrostomy, or PEG tube. This is usually done by gastroenterologists using an endoscope.
How does that work?
They pass the endoscope into the stomach, identify a suitable spot on the abdominal wall, make a small incision, and then pull a feeding tube through, securing it so the stomach wall is held snugly against the inside of the abdominal wall, usually held by an internal bumper or cuff.
Why is that snug fit important?
It's critical to create a seal and prevent leakage of gastric contents into the peritoneal cavity around the tube site, which could cause peritonitis, a serious infection.
Are there alternatives if PEG isn't possible, maybe due to anatomy?
Yes. If endoscopy is difficult or unsafe, maybe due to previous surgery distorting things, or a tumor in the head, neck, or esophagus blocking the way, then a radiologically inserted gastrostomy, or RIG, can be done.
How's that different?
Interventional radiologists use X-ray or ultrasound guidance to place the tube, often securing it with an internal balloon or a pigtail catheter coil instead of a bumper. Surgical gastrostomy is also an option, but less common now, reserved for when PEG or RIG aren't feasible.
And these tubes aren't without risks either.
No, definitely not. Any procedure carries risks. Perforation of the bowel during insertion, bleeding, infection around the site, which is actually quite common, and the ongoing risk of leakage or peritonitis if the seal isn't maintained.
What about removing them eventually?
With long-term tubes, the tract between the skin and the stomach can become permanent, lined with epithelium. So when you remove the tube, sometimes the hole doesn't close on its own, leaving a persistent gastric fistula that might need surgical closure.
And jejunostomies. You mentioned placing those during surgery sometimes.
Yes, often placed surgically, either open or laparoscopically, during major upper GI operations like esophagectomies or Whipple procedures, specifically to allow early postoperative feeding into the small bowel, bypassing the stomach and upper GI tract, which might take time to recover.
Similar complications to gastrostomies.
Generally, yes. Bleeding, displacement of the tube, leakage causing peritonitis, which is often more dangerous with jejunal contents, infection at the stoma site, blockage, granulation tissue forming around the exit site, they require careful management. Hashtag tag DAD. Complications of enteral feeding, summary box 25.3.
Okay, summary box 25.3 pulls together the complications of EN. We've touched on the tube-related ones, malposition, blockage, leakage. What about the GI side effects?
GI issues are really common. Firstly, EN is absolutely contraindicated if there's a complete mechanical bowel obstruction or a severe paralytic ileus feeding into a non-moving gut, massively increases the risk of vomiting and aspiration.
What about side effects when the gut is working?
Diarrhea is probably the most frequent problem, reported in over 30% of patients getting tube feeds. It can be due to the feed composition, rate of infusion, medications, or underlying infection like C. diff. It compromises absorption and can cause dehydration and electrolyte loss.
Other common issues.
Bloating, nausea, vomiting, abdominal cramps are also pretty common reasons why patients might not tolerate the feed well, requiring adjustments to the feed type or rate.
And the big systemic risk we keep coming back to.
Metabolic and biochemical problems. Primarily electrolyte disturbances, including, of course, refeeding syndrome if feeds are started too quickly in a malnourished patient. Vitamin and mineral deficiencies can also develop over time if not monitored, and potential drug interactions via the tube.
Right, so that's EN, but what if the gut simply cannot be used? Obstruction, massive resection, severe fistulas, then we have to bypass it entirely.
Then we turn to parenteral nutrition, or PN, delivering all the necessary nutrients directly into the bloodstream intravenously. If it provides everything, it's called total parenteral nutrition, TPN. Sometimes it's used just to supplement inadequate gut function. Hashtag tag A, indications and composition.
What's the main reason someone would need TPN?
The primary indication is true intestinal failure, the inability to absorb sufficient nutrients, fluids, and electrolytes via the GI tract to maintain health. The classic example is short bowel syndrome after a massive resection.
Other situations.
Also used temporarily for conditions causing prolonged inability to use the gut, like intractable vomiting, e.g. hyperemesis gravidarum, severe prolonged paralytic ileus after surgery, high-output intestinal fistulas where feeding makes the output worse, or sometimes severe acute pancreatitis.
What's actually in the TPN bag? It looks complex.
It is complex. It's usually prepared aseptically by the hospital pharmacy, typically as a 3-in-1 mixture in a large, often 2 or 3 liter bag. It contains everything the patient needs.
Meaning?
A lipid emulsion for fat calories and essential fatty acids, a solution of essential and non-essential amino acids for protein building blocks, concentrated glucose solution for carbohydrate energy, plus all the necessary electrolytes, sodium, potassium, chloride, calcium, magnesium, phosphate, trace elements, zinc, copper, selenium, manganese, chromium, and vitamins.
Is the ratio of fuels important?
Very important. The energy content needs to be balanced with the protein-nitrogen content. Usually aim for 150-250 kilocalories per gram of nitrogen provided. This ensures the amino acids are actually used for building protein, anabolism, not just burned for energy. And typically, fat provides about 30-50% of the non-protein energy.
We talked about phosphate being critical for refeeding. How much is usually in a TPN bag?
Standard bags contain around 20 to 30 millimoles of phosphate per day. This is essential because starting PN drives phosphate rapidly into cells for metabolism, making ATP. Without adequate replacement, severe hypophosphatemia develops quickly, which is a hallmark of refeeding syndrome and can cause muscle weakness, respiratory failure, and cardiac arrest.
And for patients on TN long-term, do micronutrients need special monitoring?
Yes, absolutely. The source recommends checking levels of things like zinc, copper, selenium, iron, ferritin, B12, folate, and vitamin D regularly for anyone on PN for more than about 28 days, and then maybe every 3 months for those on lifelong home PN. Deficiencies can sneak up and cause significant problems like skin changes, hair loss, anemia, or bone disease. Hashtag B, administration of parenteral nutrition.
Okay, so we have this complex, life-sustaining fluid. How and where do we infuse it? You mentioned it has high osmolarity.
Extremely high osmolarity, much higher than blood. That's because all those nutrients are concentrated into a relatively small volume. Because of this, TPN must be infused into a large central vein where the blood flow is very high, allowing for rapid dilution.
Yeah, exactly.
Ideally, the tip of the infusion catheter should sit in the lower third of the superior vena cava, SVC,
Right.
or at the junction of the SVC and the right atrium, the atriocaval junction.
Why not a peripheral vein, like in the arm?
Infusing such a hyperosmolar solution into a small peripheral vein would cause immediate severe chemical thrombophlebitis, inflammation, and clotting of the vein. It's painful and damages the vein quickly. Peripheral PN, PPN, with lower osmolarity formulations is sometimes used for very short periods, less than 14 days, but it's generally avoided if possible due to the high phlebitis risk.
So we need central venous access. What kind of lines are used?
Depends on the expected duration. For short to medium-term use, say weeks to a few months, a PICC line, peripherally inserted central catheter, is very common. That's inserted into a vein in the upper arm, like the basilic vein, and threaded up until the tip is in the central circulation.
Okay. Other options.
For shorter-term acute use in hospital, a standard non-tunneled central venous catheter, CVC, inserted into the subclavian or internal jugular vein in the neck chest is often used.
And for long-term, home PN.
For patients needing PN for months or years, we typically use a tunneled cuffed catheter, like a Hickman or Broviac line, or an implantable port device. The tunnel and cuff under the skin act as barriers to reduce the risk of infection traveling up the line tract.
Any veins to avoid.
Femoral lines, inserted in the groin, are generally strongly discouraged for PN due to a much higher risk of infection and thrombosis compared to upper body sites.
And just like with feeding tubes, confirming the line position is essential before starting TPN.
Absolutely mandatory. A chest x-ray must be done after insertion and before the TPN infusion begins.
What are you checking for on the x-ray?
Primarily confirming the tip position is correct in that lower SVC or atriocaval junction. Also checking for any immediate complications of insertion, like a pneumothorax, collapsed lung. Starting TPN through a misplaced line, say if the tip went up the jugular vein or too far into the heart, carries significant risks like thrombosis or arrhythmias.
Are there any special handling precautions for the TPN bag itself?
Yes. TPN solutions containing vitamins are light sensitive. The vitamins degrade quickly when exposed to UV light, so the bag must be covered with a special, opaque, light-protective outer bag during infusion.
What if the infusion gets disconnected?
Because of the high risk of bacterial contamination, if the TPN line is disconnected from the patient for any reason, the bag and the remaining infusion set should be discarded. You cannot reconnect a bag once the sterile system has been broken.
And tracking the volume infused.
Crucial. TPN often runs at a constant rate over 12-24 hours, and the total volume can be large, 2-3 liters or more. This volume must be meticulously accounted for on the patient's fluid balance chart to prevent inadvertent fluid overload, especially in patients who might also be getting other IV fluids or have heart or kidney problems. ## nutrition. Summary box 25.4.
PMBN is clearly life-saving in the right context, but Summary Box 25.4 makes it clear it also comes with significant, potentially life-threatening risks. Let's break them down. First, complications related to just inserting the line.
Yes, mechanical risks during insertion. Pneumothorax, a collapsed lung, is the most common significant one, occurring in maybe 0.51% of insertions, especially with the subclavian approach. Usually needs a chest drain.
What else?
Misplacement of the catheter tip, which is why that post-insertion x-ray is mandatory. Arterial puncture, bleeding, nerve injury, air embolism. These are less common but serious potential risks of central line insertion.
Okay, once the line is in and being used, what are the main complications? Infections seem like a big one.
Line sepsis is the Achilles heel of PN. It occurs in up to 15% of patients on long-term PN and carries high rates of morbidity and mortality. The catheter provides a direct route for bacteria or fungi into the bloodstream.
How is it managed?
A strict aseptic technique for all line handling is paramount for prevention. If sepsis is suspected, fever, chills, instability, you need paired blood cultures, one drawn through the line, one from a peripheral vein. If they grow the same organism, especially with the line culture flags positive much faster, it strongly suggests the line is the source. The line usually has to be removed immediately, and appropriate antibiotics or antifungals started. Fungal infections are particularly nasty and can spread to eyes, uveitis, or heart valves, endocarditis.
What about clots, thrombosis?
Also not uncommon. A clot can form around the catheter tip or within the vein itself. This can lead to pain, swelling, blockage of the vein, like SVC occlusion, or even pulmonary embolism if the clot breaks off.
Treatment for thrombosis.
Usually involves anticoagulation, blood thinners. Sometimes thrombolysis, clot-busting drugs, or endovascular procedures are needed for acute severe occlusions. Regular flushing helps prevent blockage, but sometimes lines still clot off and need replacing.
Okay, insertion risks, line risks. Now the third category, metabolic complications. And top of that list has to be refeeding syndrome again.
Absolutely. This is probably the most critical metabolic complication to understand and prevent, whether starting EN or PN in a severely malnourished patient.
Remind us again what happens.
When you suddenly provide a large nutrient load, especially carbohydrate, to someone who's been starved, their metabolism rapidly shifts from breaking down stores, catabolism, back to building things up, catabolism. Insulin levels surge.
And this causes?
This drives key electrolytes, phosphate, potassium, and magnesium rapidly out of the bloodstream and into the cells, where they're needed as cofactors for all that new metabolic activity. The serum levels plummet. Fluid shifts also occur.
How do we know who's at high risk? Summary box 25.5 gives criteria.
Yes. NICE guidelines provide clear risk criteria. A patient is considered high risk if they meet either 1, severe criterion, or 2, moderate criteria.
What are the severe criteria?
Severe includes BMI less than 16 or unintentional weight loss greater than 15% in the last 6 months, or little or no nutritional intake for more than 10 consecutive days, or already having low levels of potassium, phosphate, or magnesium before you even start feeding. Any one of those puts them in the high-risk category.
And the moderate criteria need 2 of these.
Yes. Moderate includes BMI less than 18.5 or unintentional weight loss greater than 10% in 3 to 6 months, or little or no intake for more than 5 days, or a history of alcohol abuse, or being on certain drugs like insulin, chemotherapy, diuretics, or antacids. Having any 2 of these also flags them as high risk.
And the clinical consequences of refeeding syndrome if it's not prevented or managed.
They could be devastating and fatal. The electrolyte shifts cause cardiac arrhythmias, profound muscle weakness, including respiratory muscles, leading to respiratory failure, heart failure due to fluid shifts, confusion, seizures, coma.
So management is all about slow and steady.
Slow start, gradual increase, maximum 10 kilogram per day initially for high-risk patients, sometimes even less, like 5 kilocalories a day. Aim to reach their full nutritional requirements very slowly, maybe over 4 to 7 days.
And electrolyte monitoring.
Intense monitoring. Check potassium, phosphate, magnesium levels daily, sometimes even twice daily in the first few days. Replace electrolytes aggressively, often needing large IV doses, and critically, give supplementary thiamine before starting the feed and continue it, along with other B vitamins and trace elements.
Beyond refeeding, what are the other major long-term metabolic issues with PN? Liver problems.
Yes, liver dysfunction is common, affecting perhaps 25% of long-term PN patients in some degree. It often starts as simple fatty liver steatosis, which might be benign. But in some patients, it can progress to more severe inflammation, fibrosis, and even cirrhosis.
What's that called?
Severe progressive liver disease related to intestinal failure, and PN is termed intestinal failure-associated liver disease, or IFOLD. It's a major cause of morbidity and mortality in long-term PN patients.
Are there risk factors for IFOLD?
Yes, things like having very short bowel, especially without a colon in continuity, seem to increase risk. Also, possibly related to excessive energy or fat content in the PN formulation, or perhaps specific nutrient deficiencies or toxicities over time. Managing it is complex.
And bone health is another concern.
Metabolic bone disease, yes. Long-term PN patients are at high risk of developing osteoporosis or osteomalacia, softening of the bones, leading to increased fracture risk and sometimes kidney stones.
How is that managed?
Prevention and treatment involve ensuring adequate calcium, phosphate, and vitamin D intake, often needing specific monitoring and supplementation, and sometimes using bone protective medications like bisphosphonates. It highlights again that while PN is life support, it's not a perfect physiological replacement long-term. ###NAMIX. Summary and conclusion.
Wow. We have covered a huge amount of ground there, right from the basic metabolic responses to the intricate details and risks of artificial feeding.
It's a massive topic, but absolutely central to surgical care.
So pulling it all together, the core message seems to be the absolute necessity of careful, safe assessment, matching fluid therapy precisely to losses, and providing timely nutritional support.
Exactly. And always considering the impact of the underlying disease and the surgical intervention itself. That dictates the patient's requirements and the best way to deliver the nutrition.
Safety seems paramount, especially around preventing those metabolic complications like refeeding syndrome.
That has to be front and center. And choosing the right delivery mode, always favoring enteral nutrition, using the gut whenever possible because of its benefits beyond just calories.
And it's clear that managing these complex patients, especially those needing long-term support, isn't a one-person job.
Absolutely not. The role of the specialist, multidisciplinary nutrition support team is fundamental. That team includes doctors, specialist dietitians, nurses, pharmacists, sometimes speech therapists,
Working together.
working together to ensure safe initiation of feeds, ongoing monitoring, managing the inevitable complications, and, crucially, planning the often complex transition for patients going home on tube feeds or parenteral nutrition. It's about safety and quality of life.
For those patients who do depend on PN long-term, like severe short bowel syndrome, the ultimate dream is always weaning off, achieving gut autonomy, right?
That's the holy grail. PN is life-saving, no question. But as we've discussed, the long-term complications, the liver disease, IFAL, the bone disease, the recurrent line infections, they are profound and limit quality and length of life.
So as a final thought for our listeners, thinking about that transition off PN.
Yeah, consider this challenge. If you have a patient who's been on home parenteral nutrition for, say, a year or two after massive bowel resection, what specific measurable criteria would you actually prioritize to decide if they have adapted enough to safely come off PN?
It's not just about maintaining weight, is it?
Is it just weight stability? Sure. Or do you need to see their stoma output consistently below a certain volume? Does their acid-base status need to be normal without IV fluids? Have they demonstrated they can absorb key micronutrients orally?
That's a really complex judgment call.
It is, because getting it wrong has huge consequences. But making that determination correctly, transitioning someone from lifelong IV dependency back to gut autonomy, well, that's a massive success. It's a complex decision that truly changes their entire existence.
That distinction between just stabilizing someone on support versus achieving true independence from it, that really is the ultimate challenge here. Thank you for walking us through all of that.
My pleasure. It's crucial stuff.
Indeed. We hope this deep dive into perioperative nutrition and fluid management has given you, our listeners, a solid framework and accelerated your understanding of this vital subject for revision and practice. Thanks for joining us.
Until next time.